Assalamu alaikum. मैं Dr. Taha हूँ, for those of you who haven't joined now. And I'm a consultant rheumatologist. My topic of presentation right now is vasculitis. I will start with a case, or here I will go over different aspects of vasculitis. This is a case I saw almost 10 years ago. So this is pre-COVID. So अब अगर present करें, I think the first thing we will do is get a PCR COVID-19 swab. But unfortunately or unfortunately, this was a long time before COVID ever presented. I met this 60-year-old gentleman who had come up with 1 month history of headache, neck stiffness, night sweats, unko joint pains bhi the, lethargy thi, weight loss tha. He'd gone to his general physician initially and they couldn't find a reason for it. He was given some antibiotics. He wasn't improving. He was losing a lot of weight. And was also just not generally feeling well. So he presented to the medical admissions unit in Scotland. His past medical history was significant for serous otitis media with bilateral grommet insertion. He had osteoarthritis, osteoporosis, and he was on medications including a PPI, alendronic acid, some codeine for pain, and recently started on Augmentin for his symptoms. Social history, he didn't smoke or drink alcohol. He was a white Caucasian, had never been in a place jahan par TB ki prevalence zyada hai. On examination, his observations were unremarkable. Oxygen saturation 95% thi. Systemic examination was unremarkable. No lymphadenopathy, no rashes, and no neurological deficits. He got these laboratory investigations done. His full blood count or complete blood count showed that his white cell count was mildly raised, platelets थोड़ी सी up थी, neutrophils high थे, Chem7 normal था, calcium normal था, liver test जो थे, albumin slightly down था, CRP, ESR दोनों significantly raised थे, और coagulation normal थी. He got a chest X-ray, he got a urine, everything was within normal limits, except this raised inflammatory markers. Now, over here, when somebody comes with headache, neck stiffness, although this is over a prolonged period of time, you think there's something wrong with their meninges. So the working diagnosis initially was, does this guy have meningitis? And unlikely to be viral or bacterial because this was going on for a few weeks now. And the other question was, with weight loss, generalized symptoms, does he have a lymphoma? Anyway, so he had further investigations. He got a CT, which showed nothing remarkable. He got the LP, which wasn't normal because it showed an increased white cell count. Now, a normal LP is white cell count should be 0 or less than 5. And all the white cell counts were lymphocytes. His glucose level was normal compared to his blood glucose. Protein इनके raised थे, और बाकी acid fast bacilli CSF culture पे किए थे. There were no acid fast bacilli. They did the PCR for viral etiologies, which was negative. And cytology also did not show any abnormal lymphocytes. So initially on the first day, I think it was a junior who saw him, wasn't sure. LP showed some white cell count. They started them on acyclovir, treating him for HSV encephalitis. But then after a couple of days, this was stopped. We looked at the history and the results, and the first diagnosis they were thinking about was whether this is TB meningitis or some kind of malignancy like lymphoma. Over time, he had further investigations requested. MRI hua, unfortunately, he couldn't tolerate it initially. He was claustrophobic. A CT scan of his chest, abdomen, and pelvis was done, which showed some basal scarring on his lungs and some small mediastinal lymph nodes. Then neurology was consulted, and they again requested an MRI brain. They said, repeat the LP. Make sure it's not sarcoidosis. the tests which were remaining were performed, including echo and blood cultures. Bone marrow was performed to make sure this is not tuberculosis or lymphoma. And somebody also mentioned vasculitic screen, to do a vasculitic screen. MRI brain, this time the patient was able to perform it because we gave him something to relax him. This was abnormal. It showed that his posterior fossa meninges on the left side were abnormally enhanced. There was some fluid in the mastoid sinus, and according to the report, the MRI stated that this could be malignant or granulomatous disease. ID was at that time consulted, and because there was nothing to lose, they started treating him on anti-tuberculous medications. So this was probably a week, 10 days while the patient was in. Despite being on the anti-tuberculous medication, the patient continued to lose weight. So this is just a summary of the search for a cause. He had the first lumbar puncture, जिसमें lymphocytes raised थे, raised protein था और सारे lymphocytes थे. Second lumbar puncture पे भी यही नजर आया. Early morning urine tests for acid-fast bacilli were done. These were negative. Montox was negative. Bone marrow भी इस patient का हो गया, कोई granuloma वगैरह नहीं नजर आए. And quantiferon gold for latent TB was done. This was also negative. Other tests to make sure everything was okay were done. HIV was negative. Serum ACE was normal. Electrophoresis was normal. Benz-Jones proteins negative. Serology for syphilis and Borrelia was negative. The only thing positive here is the urine protein to creatinine ratio, which was raised at 116. And this gentleman had, by this time, no improvement on anti-tuberculous treatment. Now, as I mentioned before, there was one thing which was also done, which was the vasculitic screen, and which included ANA, ANCA complement levels. The results came, and we found out that this gentleman, as ANCA was strongly positive, and this was compatible with primary systemic vasculitis. He was ANA negative, complements were normal. At that point in time, rheumatology was consulted. He was started on IV high-dose steroids. Before that, we decided to send a nasal biopsy because he was complaining of some nasal symptoms to get the diagnosis right. And then after IV steroids, patient was sent home on oral steroids. But before he was sent home, we got the results of the nasal biopsy, which showed इसको necrotizing vasculitis था, which was most likely either due to GPA or microscopic polyangiitis. Before discharge, he was given IV cyclophosphamide, and then we followed him in the rheumatology clinic. So this is a typical case of vasculitis. It takes some time even for doctors to realize that this could be vasculitis. And you have to do certain tests like ANCA in the right clinical setting to get to the diagnosis. Otherwise, even with a lot of physicians who are not used to dealing with vasculitis, they can miss the diagnosis. So that was the case. Now I'll just talk about vasculitis. So vasculitis is basically, in simple terms, inflammation of the vessel walls. It's characterized by presence of inflammatory leukocytes in the vessel walls. एक इंटरनेशनल चैपल हिल कॉन्सेंसस कॉन्फ्रेंस 2012 में हुई थी जिसने इसका nomenclature बनाया था. And vasculitis is classified according to the size and the type of vessel involved. Vasculitis can happen or occur as a primary process, or it can happen as a secondary condition to an underlying disease. Vasculitis is often a serious and sometimes fatal disease, so it requires prompt recognition and therapy. And treatment जो है वो काफ़ी complex हो सकती है, तो it's important कि rheumatologist, if we're thinking vasculitis, then we involve the right specialist early on. because agar we don't diagnose it or we don't understand the extent of the disease, then treatment जो है वो सही नहीं होगी. Now I'll go back on classification. Vasculitis जो है, it's basically divided into large vessel, medium and small vessel vasculitis. Large vessel जो है वो Takayasu's or giant cell arteritis हो सकती है. Giant cell arteritis is synonymous to uh, temporal arteritis, and we see it quite commonly. Medium vessel vasculitis is polyarteritis nodosa, or what we call as PAN, and Kawasaki disease. Primary CNS vasculitis भी medium vessel vasculitis आती है. And then there's a group of small vessel vasculitis, ANCA associated. Then there's the Hinox-Schönlein purpura, which is now called IgA vasculitis. Then you can have vasculitis associated with cryoglobulinemia, hypersensitivity vasculitis, and vasculitis secondary to connective tissue disorders and viral infections. This is a table. You can make it a bit bigger on your screens. It talks about the primary vasculitis and how vasculitis is divided. So there's large vessel vasculitis for medium, then small. Then you can have vasculitis associated with other diseases like Behçet's के साथ हो सकता है, Cogan's disease syndrome के साथ हो सकता है. And then you can have vasculitis as a secondary phenomenon to systemic diseases like sarcoidosis है, rheumatoid arthritis है. Actually, there is this vasculitis associated with cryoglobulinemia. ये is seen in patients with hepatitis C. So it's important to do a viral screen if we're suspecting cryoglobulinemia. Clinical features suggestive of ANCA-associated vasculitis may, if somebody comes in with mononeuritis multiplex, if somebody has a foot drop, so please think of vasculitis. If somebody has palpable purpuras or they have systemic involvement, if there's renal involvement, pulmonary, then the things to consider are small vessel vasculitis or anti-GBM antibody disease. This is just a small picture of purpura, although usually it's seen in the lower extremities. So diagnostic approach, as we've all talked about, it starts with history. We need a full history from the patients, how long the symptoms have been for, कोई नया drug तो इस्तेमाल नहीं किया, any previous history of hepatitis. Then physical examination, if there's any evidence of mononeuritis, multiplex, palpable purpura, then involving laboratory tests. So first, the laboratory tests are just the routine ones. You can do a complete blood count, KM7, liver function test, ESR, hepatitis serologies, muscle enzymes, a CPK, a urine analysis, a protein to creatinine ratio, chest X-ray, ECG. Others are more specific and may include imaging, including imaging of brain or CSF investigations, including after doing an LP. Specific tests in rheumatology are ANA, complements, and ANCA. And for vasculitis, ANCA is probably the most important one. So immunology, I'll just quickly go over ANA. We do ANA quite a lot. ANA is not usually positive with vasculitis. And having a positive ANA does not mean that you have a connective tissue disease, because it can be seen in low titers in normal people as well. A positive ANA will suggest connective tissue disease, especially SLE, and we have to look at for specific antigens. And after ANA is positive, we usually get ENA, double-stranded DNA, etc. Complements are also seen most commonly in lupus or mixed cryoglobulinemia, but ANCA-associated vasculitis, we don't really see low complements unless there is renal involvement. So ANCA is the test जो कि vasculitis में सबसे ज़्यादा commonly positive होता है. अच्छा, a little bit more on ANCA. There are two types of ANCA assays. पहला जो होता है वो indirect immunofluorescence assay होता है, which is used as a screening test. If this is positive, then we look for specific antibodies and we do an ELISA test. So in the first test, which is the immunofluorescence assay, is more sensitive and ELISA is more specific. and anybody who has a positive indirect immunofluorescence assay will be tested with ELISA to look for specific antibodies. ANCA testing is not standardized, so different laboratories will have different normals. And the two relevant targets जो हम देखते हैं वो PR3 और MPO होते हैं, और ये usually neutrophils या lysosome के monocytes के lysosomes पे होते हैं. Antibodies to these specific antigens are basically called PR3 ANCA and MPO ANCA. So the immunofluorescent patterns in vasculitis are, so first is the C ANCA. इसमें cytoplasmic staining होती है, and the antigen positivity mostly with C ANCA is PR3. And this is basically a photograph of it. So the cytoplasm is stained. The other one is P ANCA, and this is basically a staining pattern around the nucleus. Antibody which is responsible for this pattern is MPO. And this is how you see P ANCA. So once, if you get ANCA staining positive, then you will look for the specific antigens. Although not diagnostic, if somebody has ANCA to PR3, then it suggests GPA, granulomatosis with polyangiitis, जो कि पहले Wegener's कहलाता था. और जो दूसरा MPO, it's positive for P ANCA and is usually seen in microscopic polyangiitis. अच्छा, यहाँ जो मैं एक important बात कहने की कहूँगी वो ये कि in severe generalized small vessel vasculitis, you can get positive ANCA in 80 to 90% of the patients. लेकिन in localized disease, you might not have ANCA positive. So if the clinical suspicion is high, and ANCA is negative, so you cannot say this patient does not have vasculitis. And in patients who have localized disease, you can have ANCA can be negative in 40% of the patients. So just a quick summary for ANCA. The results for ANCA should be considered in a specific clinical setting. Diagnosis of vasculitis often requires a tissue biopsy. Negative ANCA does not exclude the diagnosis of small vessel vasculitis, and the positive test does not necessarily mean कि vasculitis है. और ANCA जो है वो सीरियली आपको ये नहीं बताएगा अगर किसी को vasculitis है कि अगर ANCA गायब हो गया तो पेशेंट रिमिशन में चला गया, या ANCA हाई हो गया है तो वापस से फ्लेयर हो गया है. You do it, but you look at the patient in the clinical setting and then decide what needs to be done. Other tests can be, which can be useful depending on the symptoms, can be EMG. It could be any form of imaging, including arteriography or MRA. But in the end, if we're suspecting vasculitis, then tissue biopsy is the key. Now, I would like to talk about a little bit about treatment, because treatment, vasculitis is a big topic, and the treatment will be is disease and organ specific. It can involve usage of high dose steroids and other immunosuppressive agents, or sometimes with vasculitis like IgA nephropathy can be self-limiting, so we can just give them supportive treatment. So I will go over very quickly on ANCA-associated vasculitis. It involves basically therapy, remission induction, जिसमें high dose steroids देंगे, and then you can give them strong immunosuppressive drugs like cyclophosphamide or rituximab. Then you maintain the therapy and maintain the remission by tapering the steroids and then starting them on other immunosuppressive agents like azathioprine, methotrexate, or rituximab. और monitoring in patients की जो है वो possibly lifelong होनी चाहिए, but again, patients usually disappear after the first, remission. I would like to quickly talk about giant cell arteritis, क्योंकि बहुत commonly temporal arteritis commonly देखा जाता है, or depending on the symptoms, it requires high dose steroids, or in treatment failures, other immunosuppressive agents like methotrexate or tocilizumab can be used. So about treatment, जो vasculitis की presentation होती है, it can be varied. It can have a delay in diagnosis, or failure to recognize the extent of the disease. If that happens, there can be substantial morbidity or even mortality. इसलिए I feel that it's quite important to involve specialists in the course of the disease. A quick summary about it. Routine laboratory tests in vasculitis are non-specific. Common abnormalities seen can be increased white cell count, increased platelets, increased inflammatory markers. ANCA are supportive. Gold standard is the tissue biopsy. Vasculitis can present insidiously and non-specifically, and it's a disease which is difficult to diagnose, but is treatable. Therefore, it's important to get the specialist involved sooner than later. Thank you. Any questions? Ma'am, what medicine for uric acid pain? If somebody has gout, तो आप वही acute flare के लिए वही 3 चीज़ें इस्तेमाल कर सकते हैं जो मैंने पहले बताई हैं, anti-inflammatory with PPI या colchicine या steroids. लेकिन अगर आप बात कर रहे हैं asymptomatic hyperuricemia की, तो unless you have gout or the things I mentioned कि किसी को chronic kidney disease है या increased tendency of gout है, तो asymptomatic hyperuricemia खाली treat नहीं किया जाता. Does Purpura also treated with immunotherapy or steroids? NAG Purpura is not really treated. It's a sign of the disease. So if vasculitis is treated, तो Purpura खुद ही कम हो जाने चाहिए. लेकिन अगर आप IgA nephropathy की बात कर रहे हैं, तो वो self-limiting disease है, वो खुद ब खुद बेहतर हो जाता है. Can we use IVIG for acute flares of vasculitis? डिपेंड करता है कि आप क्या चीज़ ट्रीट कर रहे हैं vasculitis की. अगर CNS vasculitis है तो I would treat them with steroids and other immunosuppressive agents, including cyclophosphamide or rituximab.